Chapter 20, Part 2, Somatic Symptom and Dissociative Disorders. So in Part 2, we're dealing with the nursing process. So first we're starting with assessment. So dissociative amnesia is defined as the inability to recall important personal information that is too extensive to be explained by ordinary forgetfulness, and which is not due to the direct effects of substance use or neurological or medical conditions. Onset usually follows some severe psychosocial stress. Dissociative amnesia continued. So the types of disturbance in recall, we have elective and selective amnesia, which are related to stressful events that have occurred. So, with localized amnesia, the inability to recall all incidents associated with the traumatic event for a specific period following the event. With selective amnesia, the inability to recall only certain incidents associated with a traumatic event for a specific period following the event. Types of disturbance and recall continued. So then we have our generalized amnesia. And generalized type, the individual has amnesia for his or her identity and total life history. Clients suffering from amnesia are often brought to general hospital emergency departments by the police, who have found them wandering confused in the streets. So they are unable to recall their entire life or any personal information. Dissociative amnesia continued. So a specific subtype of dissociative amnesia is dissociative fugue, in which there is sudden, unexpected travel away from home with the inability to recall some or all of one's past. So an individual in a fugue state may not be able to recall personal identity, sometimes assumes a new identity. And please see box 20-6 in your textbook where the DSM manual talks about the diagnostic criteria. Dissociative identity disorder, also known as DID, was formerly called multiple personality disorder. This disorder is characterized by the existence of two or more personalities in a single individual. The different personality states are sometimes referred to as an altered identity. Only one of the personalities is evident at any given time, and one of them is dominant most of the time over the other. Transition from one personality state to another may be sudden or gradual, and it can be very dramatic. Usually it's precipitated by a stressful event. Depersonalization, derealization disorder is characterized by a temporary change in the quality of self awareness, which often takes the form of feelings of unreality, changes in body image, feelings of detachment from the environment, or a sense of observing oneself outside the body. Depersonalization is defined as a disturbance in the perception of oneself. Derealization is described as an alteration in the perception of the external environment. Both these phenomena occur in a variety of psychiatric illnesses such as schizophrenia, depression, anxiety, and neurocognitive disorders. Depersonalization, derealization disorder is described as persistent or reoccurrence of episodes of depersonalization, derealization, or both. These distorted perceptions are experienced as disturbing and are often accompanied by anxiety, depression, fear of going insane, obsessive thoughts, somatic complaints, and disturbance and subjective sense of time. Please refer to box 20-6. Predisposing factors to dissociative disorder or DID. So for genetic theory, preliminary research does not show evidence of significant genetic contributions. Neurobiological theories. So dissociative amnesia may be related to neurophysiological dysfunction, electroencephalogram and abnormalities have been observed in some clients with DID or dissociative disorder. Predisposing factors for DID, psychodynamic theory. Freud describes dissociation as repression of distressing mental content from the conscious awareness. Current psychodynamic explanations reflect Freud's concept that dissociative behaviors are a defense against unresolved painful issues. Predisposing factors of DID continued. So, our psychological trauma. A growing body of evidence points to the cause or etiology of DID as a set of traumatic experiences that overwhelmed the individual's capacity to cope by any means other than dissociation. These experiences usually take the form of severe physical, sexual, or psychological abuse by a significant other in the child's life. DID is thought to serve as a survival strategy for the child in this traumatic environment. We have ourselves a question. According to psychodynamic theory, which primary defense mechanism would the nurse expect to find in a client with dissociative amnesia? So A, suppression, B, sublimation, C, displacement, and D, repression. I'll give you a few seconds. And you are correct. The answer is D, repression, which is the involuntary blocking of unpleasant feelings and experiences from one's awareness. Is the defense mechanism most used by clients experiencing amnesia. Freud believed that dissociative behaviors, including amnesia, occurred when an individual repressed distressing mental content from the conscious awareness. He believed this mechanism protected the client from emotional pain. So, nursing diagnosis. So, our common nursing diagnosis for clients with somatic symptom disorder includes the following: ineffective coping evidenced by numerous physical complaints, which is our somatic symptom disorders, deficit knowledge, and so this is a psychological cause for a physical symptom, and then we have our chronic pain related to the psychological cause for and the physical symptom is the chronic pain. Nursing diagnosis continued. So fear can be a nursing diagnosis for illness, anxiety disorder, disturbed sensory perception, for conversion disorder, self-care deficit for conversion disorder, and knowledge deficit. So this is any psychological factor that's affecting a medical condition. Nursing diagnosis slash outcomes continued. So some other common nursing diagnosis which are used for clients with dissociative disorders include dissociative amnesia. You could use impaired memory or powerlessness. For DID, you may use risk for suicide or disturbed personal identity. And for depersonalization, derealization disorder, you may use disturbed sensory perception. Client outcomes for somatic symptom disorder. So the client will cope effectively without resorting to physical symptoms. The client will verbalize relief from pain. The client will interpret physical sensations rationally and not have a significant amount of irrational fear in reference to the physical complaints. The client is free of physical disabilities and is able to verbalize understanding of the possible correlation between loss of and alteration in functioning and extreme emotional distress. Client outcomes for dissociative disorder. So the following criteria is used to measure outcomes in a client with dissociative disorders. So the client can recall events associated with a traumatic or stressful situation. The client can verbalize the extreme anxiety that precipitated the dissociation. The client can demonstrate more adaptive coping strategies to avert dissociative behaviors in the face of severe anxiety. The client can verbalize understanding of the existence of multiple personality states and the purpose they serve. The client is able to maintain a sense of reality during stressful situations. Nursing process planning and implementation. Nursing care of the individual with somatic symptom disorder is aimed at relief of discomfort from physical symptoms. Assistance is provided to the client in an effort to determine strategies for coping with stress by means other than preoccupation with physical symptoms. Planning and implementation continued. Nursing care for the client with dissociative disorder is aimed at restoring normal thought processes. Assistance is provided to clients in an effort to determine strategies of coping with stress by means other than dissociation from the environment. So the goal includes helping the client to verbalize reasons for fragmented reality, recovering deficits in memory, verbalizing psychological factors for the condition. Interventions include discussing adaptive methods of stress management, exposing the client to stimuli that represent pleasant experiences from the past, and helping the client identify stressful situations that may trigger issues such as transitioning from one personality to another. So we have ourselves a question. When working with client diagnosed with somatic symptom disorder, which is the most appropriate nursing actions? A. Avoid discussing social and personal problems. B. Focus on physical symptoms. C. Always meet the client's dependency needs. D. Gradually minimize time focusing on physical symptoms. You are correct, class. The answer is D. The time focused on physical symptoms should be minimized to avoid reinforcement. So the focus should be on the social and personal problems, which are the underlying cause for the physical symptoms. So the nursing process evaluation is based on accomplishments of previous established outcome criteria. So I'll give you a few examples of questions that you can use to evaluate how a client is doing. So this is not exhaustive. Evaluation of the nursing actions for the client with somatic symptoms may be facilitated by asking them the following questions. Can you recognize signs and symptoms of escalating anxiety? Ask the client, can the client intervene with adaptive coping strategies to interrupt escalating anxiety before physical symptoms are exacerbated? Ask them to verbalize their understanding between the correlation of physical symptoms and the escalating anxiety. So these are some evaluation questions that you could use for these somatic symptom disorder clients. So evaluation of the nursing actions for clients with dissociative disorder may be facilitated by asking them some of these questions. Can the client connect occurrence of psychological stress to the loss of memory? Does the client discuss fears and anxiety with members of the staff in the effort toward resolution? Can a client discuss the presence of various personalities within their self? Can he or she verbalize why these personalities exist? Can the client verbalize situations that precipitate transition from one personality to another? Can a client maintain a sense of reality during stressful situations? So these are a few of examples of questions you can ask for these two particular categories of mental illness. So medical treatment modalities for somatic symptom disorders. So we have our individual psychotherapy, which can be used. So the goal of psychotherapy is to help clients develop healthy adaptive behaviors, encourage them to move beyond the somatic symptoms, and manage their lives more effectively. Treatment is initiated within a couple physical examinations to rule out any pathological or diseases. The client may be more amenable to psychotherapeutic treatment, particularly stress management, when it is conducted in a medical setting. So then you have our group psychotherapy. So group therapy can be helpful to somatic patients experiencing somatic symptom disorders because it provides a setting where the client can share their experiences of illness and can learn to verbalize thoughts and feelings and can be confronted by group members and leaders when they reject responsibility for maladaptive behaviors. Then we have our cognitive behavioral therapy and psychoeducation. So psychoeducation for the family members and other support focuses on teaching these individuals to reward clients' autonomy, self-sufficiency, and independence while while carefully not reinforcing passive and dependent sick role behavior. The process becomes more difficult when a client is very regressed and the sick role is well established. So in our psychopharmacology, there's medication treatment. So antidepressants may be used. SSRIs are a type of antidepressants. Sometimes they use benzodiazepines, which are anti-anxiety agents, to treat these particular clients as well. Medical treatment modalities for dissociative disorders. So we have our individual psychotherapy, and we also have hypnosis, supportive care, cognitive therapy, group therapy, integrative therapy, and psychopharmacology. So, many cases of dissociative amnesia resolve spontaneously when the individual is removed from a stressful situation. However, in some instances, psychotherapy is used as a primary treatment, and the techniques of persuasion and free directed association are used to help the client remember. In other cases, hypnosis may be required to mobilize the memories. Then we have cognitive therapy that has been added, and the client begins to correct cognitive distortions about the associated trauma. They develop better recall of details about the traumatic event. The goal of therapy for clients with DID is to optimize the client's functional and potential. The achievement of integration is usually considered desirable, but some clients choose not to pursue the lengthy therapeutic regimen. In these cases, resolution or a smooth collaboration with other subpersonalities may all be that is realistic. So clients are assisted to recall past traumas in detail. They may experience they may mentally re-experience the abuse that caused their illness. This process of remembering with feeling is sometimes painful to the client and can cause them to cry, scream, or feel pain that they felt at the time of the abuse. So for our psychopharmacology, these individuals may be treated with either a single medication or it could be a combination. So we have our antidepressant medications, our mood stabilizers, anticonvulsants, antipsychotics, and these may be ordered individually or they may be a combination of different types of drugs to help stabilize the patient.